I think that hepatitis C is something that most all of you are aware of and participate in its diagnosis and care at a variety of levels. So I'd like to begin tonight with some general aspects to whet the appetite for those of us that have the opportunity to screen people and to establish a diagnosis, which we're lagging on as we establish the therapeutic options available. So we begin with a estimated analysis of hepatitis C cases that go beyond the National Health and Nutrition Examination Survey methodology that would suggest that we may have more than 5.2 million Americans with chronic hepatitis C in the U.S., with a prevalence a little bit over 2%, 1 in 50. And you can see what the NHANES estimate is in comparison at 3.2 million, which is going to be the official word. We know that when you look at the parenterally transmitted viruses, HIV, hepatitis B, HBV, and HCV, that the undiagnosed component stands out for the hepatitis C group. Anywhere from 50 to 75% are undiagnosed. That means everything that we're talking about and everything that has dominated the indications for orthotopic liver transplantation in the developed world for the last 2.5 decades is in the minority of those have been diagnosed. So we know we have a problem. And if we look at estimates based on these numbers, and you look at 2015 here, you can see that liver transplantation, the development of associated hepatocellular carcinoma, decompensated cirrhosis, and liver-related deaths are all expected to rise right on through the mid part of this century if we do not do more than we're doing now. That's really the message. Now, hepatitis C differs from HIV and HBV in that it has no long-term or latent reservoir, such as the cccDNA of hepatitis B or the proviral DNA that integrates in the host genome. This is an episomal viral RNA, and as a result, viral eradication actually is a cure. And this is one of those rare diseases that can truly be cured. Now, we have used the word cure only recently, but we have always used the term after therapy of sustained virologic response, or SVR. But we do know that it is associated, when achieved, the cure is synonymous with SVR, with reduced mortality among HCV-infected persons. Here you have all-cause mortality, those without SVR, this is obviously a treated cohort, and those with SVR, and then you have liver-related mortality or the need for liver transplantation, and you can see what SVR does. But I want to point out that hepatic inflammation due to anything, non-alcoholic steatohepatitis, hepatitis B, hepatitis C, is producing an increase in premature all-cause mortality. It is a risk factor for all-cause mortality. So what's going on now? We have increased demand for hepatitis C therapy. Figuratively, they say, I want the pills to cure my hepatitis C. Let me through the door and let's see what you can do for me. Well, the fact we can do anything is that we have unraveled the hepatitis C viral life cycle and have known that the polyprotein synthesized from the single-stranded positive RNA of the virus elaborates this polyprotein to be cleaved initially by host proteases, and then the cleavage products fuse into a viral-specific protease, allowing the cleavage of the downstream particles that then form the NS5A, NS5V complex, which is necessary for the minus-stranded replication template RNA to generate a new positive-stranded RNA. And because we know about this life cycle, we know about those targets, we have developed inhibitors of this protease complex. We've developed inhibitors that target NS5A and NS5B, and this is illustrated by this particular cartoon looking at the protease, which is the NS3, NS4A fusion products, the NS5A and NS5B for the replication. And we then have this nomenclature of protease inhibitors, NS5A inhibitors, NS5B inhibitors, and with all the new names, just keep in mind that all protease inhibitors end in previr, All NS5A inhibitors end as Asvir, A, and all NS5B inhibitors end in Buvir, B. Simple way when these new names come about to kind of keep them straight. Now, it's not as simple as I've just explained it. It is based also in genotype, and the therapeutic responses may vary by genotype, and hence the choice of your drug regimen may be genotype specific. In the US, we have about 75% genotype 1, and that is a combination of 1B, about a third, and at least 2/3 1A. If you go to the areas of Egypt and the Delta, you're going to deal almost entirely with genotype 4. And you can see other genotypes varying in proportion around the world. So let's kind of begin, and we're going to go kind of rapidly here because I'm going to just leave you with this sort of impression, this afterglow. So you got to have, your tray tables up in a locked position, your seat belts fastened, because away we go. So genotype 1A and 1B, treatment duration and role of ribavirin, and this is looking at the FDA-approved Harvoni, the combination pills, sofosbuvir, hepatitis NS5B nucleotide agent, ladipasvir, an NS5A agent, and you can see what occurred with 12-week regimens and 24-week regimens with and without ribavirin. And you can immediately see with the SVRs that ribavirin was unnecessary and therefore was not allowed in the package insert because it was unnecessary. Now, if we look at treatment-experienced patients, meaning they had failed prior pegylated interferon ribavirin therapy, about 20% of them had cirrhosis, then you see that you have a little bit of difference here numerically, and this had led to the decision that if you are treatment-experienced and you have cirrhosis, you should be treated for 24 weeks rather than 12. Everybody else can be treated with 12 without ribavirin. Well, we look at the treatment-experienced cirrhotics, and that emphasized the point. We'll just go on by it. I've already made it. Then what about shorter duration therapy? Well, here the scale is truncated. We have 8 weeks without and with ribavirin versus a without ribavirin 12-week comparator. You can see very robust responses. And it turned out, when you analyze that, I boxed it in red for you, that the population that gets that very high response in only 8 weeks, non-cirrhotic treatment-naive patient population, is that has a viral load starting at less than 6 million. It's actually not an absolute cutoff, but you're actually pretty good shape if you're anywhere around 6 million to go for 8 weeks of therapy with a very high response rate. This one looks at sofosbuvir and ladipasvir for compensated cirrhotics who had previously failed a protease inhibitor therapy plus pegylated interferon and ribavirin. And this one showed from Boulier's work in France that even though they're treatment experienced and even though they're cirrhotic, where I just told you you might need 24 weeks, that this group, if you add ribavirin, can achieve that same kind of comparable response. And this has led the insurance industry, when you write for a 24-week regimen based on the package insert, to inquire whether you feel you can use ribavirin for your patient because they're going to shorten the therapy and the costs by half. Now, this introduced the 3 direct-acting antiviral regimen in the treatment-naive and treatment-experienced compensated cirrhosis. So, for interest of time, I took out the definition of that, and what it is ombidisvir combined in 1 tablet with paritaprevir, protease inhibitor, and an NS5A, which is boosted with 100 milligrams of ritonavir. It's 1 pill, and it's taken once a day. And then the third agent is dasabuvir, taken twice a day. And dasabuvir is an NS5B. And then it is with or without ribavirin. And you can see ribavirin abbreviated, the RBV. So you can see very robust responses for naive and treatment-experienced populations and a very tight confidence interval for 12 and 24-week therapy. However, it is important to recognize that when you break this down by subsets, and I don't know if I had it here, I guess I do, that you have to look at your response rates as having a fall off unless you use 24 weeks for those that were previously null responders to PEG and RIBA, meaning they really didn't budge their viral load in the first 12 weeks of therapy. And thus this is an indication that for such people, and definitely for cirrhotics, that they go 24 weeks rather than 12. So in genotype 1b, however, that subtype of about a third of the American population, it really doesn't make any difference. And so for them, you can go 12. So genotype 1a, our dominant subtype of genotype 1, you have to go longer. Well, just this month, we have had the FDA approval of the combination of daclatisvir, NS5A, and sofosbuvir, NS5B, with and without ribavirin. Daclatisvir is a BMS drug, sofosbuvir is a Gilead drug. They have been studied together, and they are now FDA approved for treatment-naive, non-cirrhotic, and cirrhotic patients with genotype 1A and 1B infections. You can see the study designs, and you can see the SVR rates here, and it can't be more robust than 100%. As you can see, although the numbers are relatively small. And these had shown that you really did not necessarily need ribavirin, although the guidance that has just come out, literally last Thursday, from the AASLD and IDSA, has shown us that for cirrhotic individuals who are treatment experienced, they would add ribavirin if it can be tolerated. So we have treatment experienced non-cirrhotic and cirrhotic patients with the 1A and 1B. Here you've got those particular patients. And then we have the new kid on the block, which is before the FDA, being reviewed for a new drug application, grasoprevir and elbasvir, a protease inhibitor and an NS5A inhibitor from Merck for 12 weeks in patients for genotype 1, 4, and 6 infections. So now I'm kind of mixing it up a little bit. And you can see the design was 12 weeks of therapy versus a placebo for the single tablet, then a delay, and then a treatment of that placebo group. And they were nicely matched. They had the right kind of mix of genotype 1A, 1B. You can see there are really small numbers of patients for genotype 4 and 6. What did they find? The use of the SVR rates. You can see the numerators and denominators here. For genotype 4, it was 100% for 12 weeks of therapy. Genotype 6, it was 8 out of 10 patients. So the kind of a tragedy and conundrum of small numbers. Now, if you look at this trial more carefully and you look at genotype 1A versus genotype 1B, and I've shown you that 1B with the prior drug regimen was easier to treat and achieve SVR at a short duration with the 3D regimen of AbbVie, you find something very interesting. And we're going to end our conversation in my lecture a little bit more granular upon this point. But all of you in infectious disease are not surprised by this, that there was a big fall off in genotype 1A if there was any NS5A variants present in the quasi-species at baseline. And if you happen to have baseline resistance-associated variants with greater than 5-fold shifts in the efficacy of that NS5A inhibitor elbasvir, you ended up with a 22% SVR. And see, it doesn't pertain. The same patient populations and the same analyses don't pertain for genotype 1B. So there's a problem now emerging in this NS5A story. This is looking at your treatment experience compared to treatment naive on the prior slides, and with and without ribavirin, and you can see the SVR rates were very nice in this population with genotype 1. However, again, the big fall off, if the population at baseline had the quasi-species. A little bit of fall off here. Interestingly, they didn't have anybody to analyze that had variants with less than 5-fold shift in this, and where they had variants here with less than 5-fold shift, in those 10 patients, they got extraordinary SVR rates. So we want to hold this variant story until the end. So what about treatment of patients who failed the prior PEG interferon, ribavirin, and protease inhibitor? I showed you a little lidiposphere data. Let's look at some additional data. You can see very robust responses with 12 weeks and maybe a little bit of a numeric difference if you add ribavirin into that mix if you've had a protease inhibitor. We look at the C salvage. This was for protease inhibitors, boceprevir, telaprevir, and cimipravir, and you can see what has gone on here. However, when we look at the prior virologic failures and the prior non-virologic failures, they were really comparable. So it didn't make much difference if you broke through in a prior therapy or you relapsed after a therapy, you could be retreated. That's really the message. And that meant that there weren't such resistance-associated variances that were going to cause this protease inhibitor, boceprevir, to be ineffective. Now, cimipravir and sofosbuvir is a combination many of you have used because it was available to us from the Cosmos work, known to be effective for genotype 1b, which is in the orange, 1a, with and without the Q80K mutation that defeats cimipravir as a protease inhibitor. And you can see that they had 24 weeks and 12 weeks of therapy. And overall, the recommendation had come about that 12 weeks of therapy be the norm. Well, we gathered data in this non-FDA approved regimen that the insurance industry really bought into in the United States in this Target 2.0 series, looking at the non-cirrhotics in red and the cirrhotics in green. This is one of those so-called real-world experiences from multiple sites, and you can kind of see what is going on here in terms of the prior PI failures in the real world. And when you looked at genotype 2 there, it's as expected, they do excellently, but genotype 1, you were still with fairly robust responses. But if you were to compare all of these to that slide a moment ago, they were all fall-offs. There seems to be something when you really get out and are treating patients, you're going to come down a notch. Not all of which has to do with the drugs, a great deal of which has to do with the patients. And it has to do with adherence, and you can track things. Did they renew their prescription on time? Did they get their second prescription, their second month on time? And you find unfortunate variation. We're going to go fast for genotype 2 because we know that all of these studies for treatment-naive and treatment-experienced patients for genotype 2 showed robust responses with some fall-off in the treatment-experienced responses in the cirrhotic population. But it still is the dominant therapy. But now we also have data, and this is what was just updated last Thursday, and these AASLD IDSA guidelines, that declatosphere or sofosbuvir for 12 weeks for patients intolerant of ribavirin is a recommendation. There are really no alternatives. So this is a new addition to our armamentarium. For the treatment-experienced chronic genotypes 2, then we have sofosbuvir ribavirin for 16 or 24 weeks, depending upon your experienced non-response being partial or null. And then we have alternative therapies, again, emphasizing that cladosphere has been added to this in combination with sofosbuvir. Well, genotype 3 has been a real problem for us, and we didn't know how much of a problem until we started to use sofosbuvir and ribavirin and have seen almost everybody breaking through. And it's an equal problem to us on the larger scale because these data from the VA showed that if you have genotypes 1, 2, or 3 with an SVR, your cumulative mortality is low and about comparable to your age and sex match population. If you don't have an SVR, you actually will have a reduction in your all-cause mortality. But if you have genotype 3 and no SVR, you do markedly worse. We don't know why that is. But remember, this is one where you basically have a liver that's not only infected, but it looks like foie gras. You know, you have 50 to 80 to 100% of your hepatocytes chock full of lipid, which is unique to this particular genotype, and it may be one of the reasons that it is so problematic. Well, here the guidelines are quite clear that for non-cirrhotics we can use declatosphere, sofosbuvir, because declatosphere is pangenotypic, as is sofosbuvir. And for cirrhotics we can use that combination with or without ribavirin. Here in the recommendation, however, now for the first time you're seeing PEG interferon, and that's based on actual data. The valent studies showed that the treatment-experienced population were not doing well with sofosbuvir ribavirin. That led to the addition of pegylated interferon to the combination sofosbuvir ribavirin. 55% of these patients were cirrhotic. You saw then much more robust responses, and that has made its way into the guidelines still. We now have the declatosphere sofosbuvir story. In this patient population, there was cirrhosis in 19 and 25% of the treatment-naive and experienced populations, and here's cirrhosis either absent or present, et cetera, treatment-naive, treatment-experienced. So what we find here is wide confidence intervals with very small numbers in the denominator, but the bottom line is that cirrhosis is not a good thing if you are treatment-naive or treatment-experienced for this genotype 3, even though it is one of the drugs just added to our armamentarium. This is entirely investigational. That's sofosbuvir from Gilead. This is Gilead's 5816. This is a pan-genotypic NS5A inhibitor, like ladipasvir, like declatosphere, like elbasvir. They're all NS5As, with or without ribavirin. And you can see the non-cirrhotic responses, very robust, with or without ribavirin. And then you can see somewhat of a fall off, and you need to get your optimal SVR, a treatment here with ribavirin in addition. But this will be forthcoming. It's through phase 3. It will be going at some time in the near future, probably for new drug application. This is ladipasvir sofosbuvir with or without ribavirin in a population which has become unique in our field. This is Ed Gain and his New Zealanders. New Zealanders do extraordinarily well with almost anything you give them, it appears to be, but you can see that ribavirin made a big difference here in the New Zealanders. So this is sort of Harvoni off the shelf, and here we have it for genotype 3 and 6 infection. But again, you see this fall off when you have genotype 3 cirrhosis. So we have not solved this problem, and to enter the field are these experimental data now before the FDA with grazoprevir, elbasvir. This is the Merck combination pill with sofosbuvir, the Gilead backbone NS5B. You can see the trial design, non-cirrhotic and cirrhotic, and you can see the non-cirrhotic and cirrhotic results. Very small numbers, but very encouraging. We go to genotype 4 and 5. I'm just going to emphasize the data here. We've got the 3D regimen for genotype 4, looking very robust here. The green is the SVR12. That's the cure rate. This is looking at ladipasvir sofosbuvir, treatment-naive, treatment-experienced, cirrhosis, yes and no. You can see it for genotype 4. That's the emphasis. Again, very robust response rates. And here you can see genotype 4, it does better with 2-DEA. Decompensating cirrhotics, I think I'm going to fly by because most of you don't deal with them. They've been a problem. Ladipasvir has been studied. It has done well, even with advanced cirrhosis, child Purcott score class C. We know that their MELD scores in the majority of these individual bars or individual patients either stayed the same or went down. A minority worsened, and this has put some people into purgatory where they're on a transplant waiting list. You just knock down their MELD score, but they still are miserable with ascites and encephalopathy and less likely to be transplanted. Here's the cladosphere sofosbuvir, and we look at the genotype 1, advanced cirrhotics and post-transplant, a very nice outcome in both. We look at grazoprevir, elbasvir, class B cirrhosis, very nice response rates, particularly compared to an advanced liver disease, non-cirrhotic, that was a head-to-head, and it looked very good. Ladipasvir, ribavirin, pre and post, you can see the genotype 1 and the genotype 4. Once again, these are very sick patients. There's child A class and B and C. Now here you have much more variation, but you have still an encouragement that we can treat for the first time our decompensated patient population. This is looking at severe renal impairment, end-stage renal disease, and here we have only 2 patients that had gotten up to the SVR12, but everybody tracking behind them had maintained a pathway to SVR using the AbbVie 3D regimen. This is the Merck regimen in the chronic renal disease patient population, and these are full set analyses now of 94% intention to treat SVR. So now what happens when they say, I took the pills to cure my hepatitis C and it didn't work. I want some new pills to cure my hepatitis C. Well, there's a retreatment study, which I'll be ending with, and that is ladipizvir sofosbuvir for 24 weeks in patients who had failed that regimen taken for 8 or 12. Now, they failed by relapse. They didn't fail because it virologically didn't work, but what happened here is that you found that only a minority actually responded, and when you broke it down, you found that these baseline RAVs were playing the big role. That's that same NS5A RAV story. And if you looked at individual resistance-associated mutant substitutions, you find this Y93 H or N substitution really takes down the ability of this retreatment to work. If you look at how long those last in this particular population, here's a 96-week analysis showing that they are still detectable in 82%. So we are creating our own dilemma about not having a retreatment strategy for all of these NS5A backbone studies. Here we see it for the phase 3 sofosbuvir program, and it's the group that had the polymorphisms that still get high SVR, but it's this little tiny part up here that you can't retreat with anything. And the same thing came out of the Merck analysis, showing that you could get SVRs within the RAV, but you saw already the individual histograms I portrayed to you that said a lot of those people will not respond. So we have to now take this all into consideration for our individual patient, and if you're going to prescribe any of these medications, you're going to want to check those guidelines because they're updated with every new piece of information, and you're going to have to get authorization. So what is that? It's voluminous paperwork that turns relatively simple all oral treatment regimens into an administrative nightmare, an obstacle created to discourage physicians from treating patients with hepatitis C infection. A system that frequently removes treatment decisions from the physician and patient, places it within the realm of an anonymous voice at the other end of the telephone, and see sections on appeals process in the twilight zone when you get involved in that. And I haven't spent much time on adverse events, in part because they're very minor, but there is a serious adverse event, and this is both national and global. And that is the most common serious adverse event appears to be poverty for the payers because they're so resistant to our seeking authorization to treat our worthy patients. For those that you have that are patients who cannot be treated or for whom there's not a guidance, there are many investigational studies, and this is my last slide, a plug for our Advanced Liver Therapies research unit. We would be happy to share what types of studies are available. We currently have many, and I thank you very much for your attention.